This was a systematic review that was published last year, and they screened all the evidence regarding this question from 1994 to 2020. And essentially what they showed, I've highlighted the significant findings. So compared to placebo, prednisolone was associated with a greater improvement in a symptom severity score at 4 hours, but that change was no longer significant at 12 hours of duration. And the other significant benefit was that it shortened the duration of a hospital stay by about 4 hours. So really, I think the take home for this is that the only evidence to support prednisolone in the preschool age group is using it in the hospital setting with the aim of reducing your hospital stay by a few hours, which, given the number of children who present to emergency departments and hospitals around the country, that's a significant saving. So the role for prednisolone in preschool asthma in the community is really, there's no evidence to support that. So this was a trial that was run in Victoria, in our state, and by predecessors in my department. And what it did was children were either parents were randomized to either self-initiate a course of prednisolone for their children or not. And what it showed in this randomized controlled crossover trial was that the benefits of parent-initiated prednisolone were really subtle reductions in asthma symptoms, healthcare resource utilization in terms of unplanned GP visits and school absenteeism, but not in more significant outcomes such as avoiding admission and emergency department presentation. And the authors of the trial concluded that the benefits were subtle and should be balanced against the potential side effects of repeated courses of oral corticosteroids. And I think this study was published at a time where probably we weren't as aware of the threshold of 1,000 milligrams or being a toxic amount of exposure to prednisolone. And I think that conclusion might even be more strongly worded now, if we had that evidence at hand. Well, certainly, I think as John nicely outlined, in the past when we had a limited number of tools in our toolkit for managing people with severe asthma, you had to reach for oral corticosteroids relatively quickly. Whereas these days we're very lucky to practice in an era where there are many more resources, and as such, guidelines such as GINA would refer to maintenance oral corticosteroids as a last resort. And so in children, there is evidence to support the use of in addition to standard things like inhaled corticosteroids and long-acting beta agonists and leukotriene receptor agonists, things like azithromycin, long-acting muscarinic antagonists, and biologics. Pediatric respiratory specialists will be very familiar with this figure from the left, which is the chart that outlines the trajectory of lung function development across the lifespan. And the graph in blue is what the normal course is, which is rapid development of lung function across your first 2 decades of life, your FEV1 peaking at about 20 and then steadily declining thereafter. But chances are you'll never get symptoms of that and you'll die from something else. However, things like poorly controlled childhood asthma will cause slower attainment of lung function across your first 2 decades of life, resulting in a lower peak lung function and a quicker decline to symptoms and death. And we think about this a lot as pediatric respiratory specialists or pediatricians or GPs or people who are trying to manage asthma the best we can so that we not only maximize the child's quality of life in childhood, but we also protect their long-term health. But we often think about protecting their long-term lung health. I guess what I've in thinking about the role of oral corticosteroids and my role in prescribing those, I'm trying to lift my awareness a little bit and advocate for others too, to also think about, well, what is our responsibility or what is our role in the long-term health of our patients outside of the lungs. And so this figure comes from the work that Asthma Australia has done and highlighting all of the side effects of steroids, which we all know about. But we need to keep in mind that if we're prescribing a preschool child with prednisolone, which we do very often, we are increasing their risk of all of these complications across the life course. John made this point, like how much is harm? And so, you know, I think he nicely illustrated the evidence of 1,000 milligrams of cumulative exposure across a lifetime being associated with harm. And what I just wanted to put that into the context of was, well, I think actually in pediatric practice, we can hit that figure quite quickly. My kind of guilty thought is that actually I'm pretty convinced that all of our patients that we transfer over to adult services probably have hit the 1,000 milligram exposure mark, and we need to, you know, and we need to be cognizant of that. Firstly, we should use oral corticosteroids in an evidence-based manner. The second thing is doing everything we can to prevent exacerbations, so to prevent the need for them. And this echoes things that John said, but you know, many people will be familiar with this publication, which was the Lancet Commission on Asthma from about 2020. One of the points was around having a zero tolerance for asthma attacks. And, you know, when someone has a heart attack, they will automatically undergo a very rigorous assessment where every risk factor is identified and everything to prevent a second heart attack is done. And we need to do the same thing after a single asthma attack. So in pediatrics, that starts by doing the simple thing, making sure the diagnosis is right. So I think there's a lot of misdiagnosis in childhood asthma. And so getting the diagnosis of the symptoms right, looking at treatable traits and the things that are relevant to pediatric practice in particular, things like allergic rhinitis and obstructive sleep apnea. You know, doing simple things like inhaler technique. This clinic was just a clinic that was not a, you know, tertiary level severe asthma clinic. It was a clinic that involved a pediatrician, a nurse, and a pharmacist, which just aimed to do an asthma assessment and some asthma education and doing, you know, that circle of asthma care as highlighted on the previous slide. And what you could see is that in 50 children, when they looked at the number of systemic courses over a year, there was a significant reduction in oral corticosteroid courses. The last thing is for the most truly severe patients with asthma, one other option we have is asthma biologics. So this is a figure from some research that we did at our asthma clinic, looking at 35 children who were treated with biologics for severe asthma. And in the previous 12 months prior to biologic initiation, the median prednisolone exposure was 610 milligrams. In 12 months, the median steroid exposure was 0. I should know that most of this data was collected in the era where PBS required 500 milligrams in 12 months of prednisolone to be eligible for a biologic. That criteria has thankfully been removed. One of the things is that when we're managing children, we're managing a lifelong condition. As children with asthma, we're managing a lifelong condition. And what we kind of train them in as appropriate asthma management in their early years is probably how they're going to manage their asthma for at least their primary school and adolescence, and if not for the rest of their life. Families just don't access GPs for routine asthma visits to manage asthma as a chronic disease. The pattern of behavior is about accessing it for acute healthcare visits to get a script for prednisolone. That doesn't work, they go to the emergency department. And then the message that they get from centers like mine is that, well, that's the right thing to do. Just keep managing asthma as a series of acute episodes and not as a chronic disease. And so I think we really need to shift the behavioral aspect around how we manage asthma.